Jim Ryan, and I'm a longtime prevention professional here in Ohio. Very excited to be here with you today. I want to get a little bit of a sense of who you are before I kind of dig into some of my content. Raise your hand if you're a clinician. Okay. Raise your hand if you're a prevention professional. A couple of you. Raise your hand if you work in the court system. Okay. Raise your hand if you were just an engaged community member. Okay, good. Who am I missing? Healthcare? Healthcare folks. Okay. Social workers? Okay, good. Thank you. Help me know a little bit about who's in the room. I want to accomplish a couple things with you over the next hour. One is to expand your understanding of prevention. Most of the folks in the room, you're not prevention professionals, you don't come from a prevention background, and we have a lot of assumptions a lot of times in our work about what prevention is. So I really want to expand the concept of what prevention is for all of us in the room. I also want you to think about what your role is in prevention. So if you're working in the court system, you're a clinician, or you're working in healthcare, prevention may not be the immediate place you go when you think about the work that you do. And we believe in the prevention field that everybody plays a role in prevention. There are prevention experts, people like myself, Daryl, etc., who are certified to help plan and implement prevention strategies. But we all play a role in prevention because the majority of the population, the majority of our family members, the majority of our friends, etc., are our prevention audience when it comes to substance use disorders. So that's part of my overarching goal for today with you all. We're going to be pretty informal, so if you have questions, again, we'll take some at the end, but just kind of jot down notes as you would like going forward. I want to start with a little definition for you here. This is a definition from Ohio MOS, the Ohio Department of Mental Health and Addiction Services, definition of prevention. So when Ohio MOS is funding the county board that then direct money to our local providers, these are the definitions that they rely on to frame the work that's being done in communities. The first there is prevention focuses on preventing or delaying the onset of behavioral health problems. Now, I have a writing background, an English background, and I am never crazy about using the word in the definition, but there it is anyway. So preventing or delaying the onset of the behavioral health problem. And we're talking specifically today, of course, about substance use disorder. The second definition talks about prevention services. This is really where I want you to focus. When we talk about prevention services, a planned sequence. Planned sequence. That means it's not just a one-shot thing. We don't just walk in the door, do a one-hour program, and assume that that's going to necessarily be effective prevention. It's a planned sequence of culturally appropriate, because we want to make sure that the strategies we're implementing are appropriate to whatever cultural group we're working with, whether that's based on age, race, gender, etc. Science-driven strategies. Science-driven strategies, and that's really, really important. One of the things we're going to talk about today is what works in prevention and what doesn't. What sometimes folks do that they call prevention that's not really prevention. Because we have a lot of science now about what works when it comes to prevention strategies. And really want to make sure you're walking out the door understanding that today. It's really, really important that our strategies, the resources that we're utilizing to implement programs within our communities are driven by science. What we know actually works based on the science, not what we might think works based on our instinct. Intended to facilitate attitude and behavior change for individuals and or communities. And one of the things that makes prevention a little bit different than those who are doing clinical work is almost exclusively focused on the individual or sometimes the family. With prevention, we're looking at the individual sometimes, or again, a family unit, for example, but we're also looking at the broader community. The whole school district, or the whole school building, the entire workplace, the entire neighborhood, again, the entire municipality. So we're also looking at strategies to try to impact that much, much larger population as well. Now, there are 6 ways we do that, what we call the 6 prevention strategies. And these are the strategies that come out of the Center for Substance Abuse Prevention on the federal level. And again, all of our prevention dollars are driven to these 6 strategies. Now, typically you'll see the strategies listed in just kind of a bullet form, 6 strategies. Dr. Tammy Collins, who has held different roles within our state a few years ago, was the Chief of Prevention Services at Ohio MOS. She always said, I'm a visual learner, and so the idea of just kind of looking at these words in bullet form didn't really work for me. So she created what we call a strategies map. And I tweaked it a little bit with her permission, and that's what you see in front of you. The first strategy we use in prevention is information dissemination. And information dissemination are things like brochures and just kind of public speaking events, billboards, PSAs, etc., that make folks aware that either there is a substance use issue that needs to be addressed, or that there are strategies or resources available for them to take advantage of. So some marketing in some ways around prevention resources and strategies and tools. Information dissemination is really important, and that's why it's first here, because we can't really do anything about anything until people know about it. We couldn't address the opioid epidemic until people knew that there was an opioid epidemic. We can't address underage drinking in a particular community until people are aware that there's an underage drinking problem within that community. We can't address risks or try to get folks to not abuse the medical marijuana until folks know that that is potentially going to be a problem within our state with the implementation of that new law. So information dissemination is really important. But here's the important thing about information dissemination. By itself, it doesn't work. We can educate folks all along and then providing information to them and let them know about a particular problem, let them know about prevention resources, etc. That by itself is not going to prevent the behavioral health problem. It's not going to prevent substance use. If it did, no one would smoke. I mean, think about it. Is there anyone out there who doesn't know that smoking is bad for them? No. And that includes kids. But we saw smokers because information dissemination by itself does not work. Sometimes information dissemination can actually make things worse, and we're going to talk about that a little bit later as well. But it's still very, very important. When we do information dissemination right, it lays the foundation for the next piece of the puzzle, which is community-based process. And that's where we're bringing people together, whether it's coalition work, whether it is working with a school district or a workplace or some other kind of system, to figure out what kind of prevention strategies make sense within this particular environment. And so it's things like today, to some degree, is community-based process. Bringing folks together, some shared learning, and folks are hopefully, again, continuing to build and enhance relationships to affect change within the community. Again, community-based process, essential to prevention, by itself doesn't do anything. We have meetings all day long. Meetings all day long do not necessarily reduce substance use within a community. Information dissemination community-based process coupled together ideally lead to the two most effective strategies, and that's education and environmental prevention. The yellow box and the red box. Now, when we look at the strategies that are most effective, it's education and environmental strategies, the two big boxes there. Now, education, one of the things about education is not just any education. Clinicians, is education a tool you use in your clinical work? Yeah, absolutely. So education is used on the clinical side of the equation as well. When people are providing treatment services, part of that treatment service is education. We also use education on the prevention side. The type of education we're doing in treatment, the type of education we're doing in prevention are different types of education. So not all education is prevention. You'll hear folks sometimes talk about, oh, we have a prevention program and we just educate folks about substance use. Well, that isn't necessarily going to, again, affect change. When we talk about prevention education, we're talking about education that, again, is science-based, a type of education that we know impacts attitudes and behaviors around substance use and prevents folks from ever either using it in the first place or using it in a way that leads them to experiencing a substance use disorder. So prevention education provides typically individual outcomes. We do education in a classroom, 6-week curriculum for 5th graders, for example. We do education within a work environment, again, a curriculum that's based in science. What we call, again, evidence-based prevention education. The other side of that, the red box, the environmental prevention is when we're looking at population outcomes. And environmental strategies are strategies we put in place to try to impact an entire population. That could be an entire population like Ohio. That could be an entire population like Portage County. That could be an entire population like a school district, etc. Or again, a workplace. Environmental strategies are bigger picture things that happen that tend to impact that entire population. Examples of that include things like laws and policies. So the opioid epidemic, one of the big things that we've seen in terms of the reduction of prescription painkiller abuse in the last few years is we've seen a reduction in prescription painkiller prescribing. And part of that is due to a change in prescribing guidelines in Ohio, policy that was changed on the state level, as well as passage of a law last year that limited the number and duration of prescribing of pain meds, opioid-based pain meds by physicians. Those are policy and law changes that, again, reduce access and availability and have a prevention outcome too. Environmental prevention can also include changing social norms. So doing things that change what's normative behavior within a community. How many of you are old enough to remember a time where no one really thought about drinking and driving? Yeah, I mean, people just got in their car and drove. That's just not really, that's not reality today. We don't think that way like we used to. And so we've changed that social norm around drinking and driving. We have slowly, though we're not quite where we want to be yet, changed the social norm about parents providing alcohol to their kids, having the graduation party and so on and so forth. That used to be very, very normative. It's still somewhat normative in some places, but it's not nearly as normative as it used to be. So we've changed the social norm about what's okay. We've changed the social norm about smoking and where it's okay to smoke. And that social norm began to change before the laws changed. Before we passed the smoking law here in Ohio that prohibited smoking in public places and workplaces and such, the social norm around that was changing. Folks would give you a look if you were smoking in your car with your kid in a baby seat in the back seat. That, no one thought about that in the 80s. Smoke all you want with your 5 kids in the car. No one thought about it. We changed the social norm, and the social norm led to, eventually, the law change. So with environmental prevention and the prevention education, those are the 2 areas we really want to focus on in terms of strategies. Everything else we do should be leading to those strategies. You'll see the 2 smaller little areas there, alternatives in the blue. Alternatives is a strategy where we're providing basically alternative activities to folks using. And this tends to be aimed at kids a lot of times. And this could be like drug-free dances, for example, or drug-free community events, etc. Those are helpful, they're useful. We always want folks to have alternatives. But those by themselves don't work. I can't tell you how many communities I've worked with over my career are like, here's what we need to do. Here's why teenagers use in our community. They don't have anything else to do. They don't have anything else to do. So we need to build a community center. And then kids won't drink and they won't get high. They're like, well, no, they'll just drink and get high before they come to the community center. Or they'll drink and get high out behind the back of the community center. Or they'll come to the community center and they go drink and get high afterwards. Building a community center doesn't automatically mean that folks aren't going to use. Building a community center coupled with prevention education and passing policies and laws, yeah, that makes sense. We are seeing in terms of the opioid epidemic, another kind of twist on the idea of alternatives. And that's getting doctors on a policy level to have conversations with their patients and to think about prescribing alternatives to opioids. So what kind of therapeutic methods can happen so that I don't necessarily need a pain medication in the first place? Or if I'm going to prescribe some type of medication, can we prescribe something that doesn't have the risk of opioids? And so alternatives are important. They typically need to be coupled with prevention education and or environmental prevention strategies. And then the little purple box there, the smallest one is problem ID and referral. And that's when, in the course of doing prevention work, we identify someone who we think maybe isn't a prevention consumer anymore. This is someone who may need treatment services. Now, I'm a long-term prevention professional. I'm not a clinician. I'm not trained and I'm not qualified to determine if somebody has a substance use disorder. So in my work, if I encounter someone who presents to me as, oh, I'm seeing some red flags, part of my responsibility is to direct that person to a resource where they can go through screening, assessment, treatment, if needed, and connect them to those appropriate resources. So again, typically a sidebar to prevention education, because that's typically when folks would encounter someone who may have those types of needs. Questions about the strategies now? The big point I want to really emphasize here again is education and environmental prevention are the 2 strategies we need to key in on. If we're doing some information dissemination, we need to be able to explain how does it lead us to a prevention education strategy that's evidence-based. or to an environmental prevention strategy, again, that we know is a successful type strategy. Questions on that? So, again, most of you in the room aren't prevention professionals, so you're not doing prevention work. Some of you are community advocates, and some of you in your roles, you may be engaged in prevention work. But the majority of folks in the room, again, raise your hand saying you're a clinician, for example. Clinicians don't do prevention as a rule of thumb. So I want all of you to think about who are your prevention consumers? Who are the people in your line of work, or the people in your personal life who do not have a substance use disorder? Who are those people? Family members. Yeah, so if I'm a clinician, I may be treating this individual. This individual has family members. Some of those family members may need treatment as well, but a lot of them don't. And that's not just kids. Sometimes it's the other adults in that family system as well. And so sometimes it's the family members of the person who is receiving clinical services. Good. Who else? Who else are who are prevention people in your life? People who would benefit from prevention services? Teachers. Good. So gatekeepers, folks who are accessing other populations who are typically going to be prevention audiences as well. Your own kids, your own family members on a personal level, the people in your life that you're not providing any kind of work type service to, but they're part of your life. They're prevention people too. They're your prevention consumers as well. We all have people in our lives who would benefit from strong prevention services. Again, whether on the prevention education level or the environmental prevention level. Our job is to figure out what's the role that we play, if we're not a prevention professional, in ensuring that those folks are receiving adequate prevention interventions. So some of you have seen this before, the continuum of care of the behavioral health field out of the Institute of Medicine. I'm not going to dig into the promotion part of it so much. Promotion is really about just making sure everybody's aware of resources and such. What I want to focus on is on your left side of the continuum, you'll see prevention. And then on the right side, you'll see treatment, maintenance, recovery as an overlap between those two. And again, this comes out of the Institute of Medicine. How many of you have heard the cucumber pickle analogy? Okay, so a few of you are familiar with this. For those who aren't, this is a really kind of simple way, I think, to understand what's the difference between prevention and treatment, and who's a prevention audience versus a treatment or recovery audience. Down the line there in the middle is kind of the divider. The folks who would be on this side, on the prevention side of the continuum, are what we would call cucumbers. Okay? Now, if I'm on the other side of the continuum, on the treatment and recovery side of the continuum, I'm a pickle. Okay? Now, can a cucumber become a pickle? Yeah, so what does that tell us about people who are on the prevention side of the continuum? Any of them, at some point, could end up needing treatment or recovery. That we're all susceptible to developing a substance use disorder or other behavioral health disorder. Okay? On this side of the continuum, pickle side of the continuum, can a pickle become a cucumber? No. I had to argue this about somebody once because he didn't understand how a cucumber would become a pickle. And so what he means, he's like, how do you, I don't get this cucumber becoming a pickle. I'm like, well, you pickle the cucumber and then that makes it a pickle. He's like, pickles grow on trees. They don't really, and I had to get other people in the room to reinforce the fact that pickles do not grow on trees. So just in case anybody was wondering about that, pickles do not grow on trees. We get pickles from cucumbers. That said, once I'm a pickle. Now I can be a crazily healthy pickle. I can be a really, really healthy pickle. I can have sustained recovery and be healthy and well. We're hearing from some people today who are really healthy pickles. And that's awesome. The strategies that keep me a healthy pickle are different than the strategies that keep me from becoming a pickle in the first place. Okay? I'm a cucumber. I'm not in recovery myself. If I was in recovery, I had an alcohol use or other substance use disorder, the recommended alcohol consumption for me would be what? 0. Abstinence. I'm a cucumber. Recommended alcohol consumption for me? Is it 0? No, zero is an option. I can choose not to drink at all. That would be a healthy choice when it comes to alcohol consumption. But we also know that there are low-risk drinking guidelines that are going to keep me at pretty low risk of ever developing a substance use disorder. And so even when we just look at some of the base information, the strategies we use are different on either side of the continuum, even based on something as simple as levels of alcohol consumption. Abstinence for one population, low-risk drinking for the other. Okay? So cucumbers and pickles. And I think that's a really helpful way for folks to understand that. So the line down the middle I always call intervention. The line down the middle is the intervention, the place that helps us figure out does somebody need treatment or not. And if they don't need treatment, then let's direct them towards, again, effective prevention strategies. How many of you watched the TV show Mom? Allison Janney, and yeah. I haven't seen it yet, but somebody just told me the other day they used the cucumber pickle analogy on Mom last week. So I'm going to chase that down, so I'm pretty excited. It's become a pretty common phraseology in the prevention field, helping folks understand the difference between what we're trying to do here. So when we look at the prevention side, we really have to think about, again, what's effective and what's going to help people stay in the cucumber place and not develop that behavioral health disorder like a substance use disorder. Now you'll see in the prevention window there are 3 wedges of the pie. Universal, selective, and indicated. I want to talk about those. Within the prevention population, you can look at that continuum to describe populations, or you can use it to describe strategies. I'm going to use it in the sense of populations for a moment. If I'm a cucumber, I'm part of the universal population. Okay? Universal cucumbers are basically all cucumbers. It's the entire population of cucumbers. Now we can section that off a little bit and say, okay, the universal population I want to address is all 3rd graders in Portage County, or it's all young adults in Portage County who, again, do not already have a substance use disorder. But universal is kind of everybody. And we design strategies to address that whole population. That's why we have prevention curricula, evidence-based prevention curricula, being delivered in school districts. And they're delivered typically to an entire classroom, an entire grade level. Okay? So that's universal strategies. There's a subset of the universal population, what we call the selective population. Selective population of cucumbers, of people who do not have a substance use disorder, are people who are at higher risk of developing a substance use disorder, typically through no behavioral issue. There's nothing going on with them behaviorally, they just happen to be at higher risk. Tell me a population that's at higher risk of developing a substance use disorder through no fault of their own. Good, children of alcoholics and addicts. Particularly if I have a biological parent with a substance use disorder, I'm at higher risk. Good. I heard somebody mention people who've experienced trauma, particularly childhood trauma. Okay? I've experienced childhood trauma. We know that there are brain changes that happen out of that. That increases my risk of developing a host of behavioral health disorders. Again, didn't do anything to create that reality for myself. I just happen to be someone who experienced childhood trauma. Or I grew up, again, in that home. Or with a parent. I have a parent who has a substance use disorder. It can be environmental. I live in a home environment where there's really easy access. Or again, a very permissive environment around substance use. So my parents don't think it's a big deal if I start smoking weed when I'm 12. And I'm hearing that kind of messaging by the time I'm 10. So we look at selective populations. We're looking at populations that, based on what we know with the science and the research, these folks are at higher risk of developing a substance use disorder. What that means is we sometimes need to develop strategies that target that population specifically. Okay? Strategies that target that population specifically. And then the third population is indicated. Indicated is another subset. Indicated are folks who, again, are not pickles. I don't have a substance use disorder yet, but you are already seeing some behaviors that indicate that some red flags with me. So I'm the person who I'm the adult who got the DUI. I'm the kid who was caught drinking or smoking weed out behind the school building. I'm someone who, again, there's some red flags here already. Again, if I went through an assessment, I'm not diagnosed as having a substance use disorder at this point, but obviously I'm at higher risk than anybody else up here on the cucumber side because I'm already engaging in behaviors that are increasing my risk of developing that disease. Okay. Questions? One of the ways ways it helped me because we changed, how many of you remember primary, secondary, and tertiary prevention, that terminology? Yeah. Delete that from your brain, we hate those words now. These came into play a number of years ago, and at first I struggled to try to figure out which term applied to selective and indicated. And the easiest way for me to understand it is we're selecting some folks for certain strategies, again, based on their higher risk. Indicated is kind of like the indicator light on your dashboard on a car. When that light comes on, that doesn't mean that my car, that my engine's about to die or that the car's about to not be able to run and is therefore going to need treatment, say. It means that it's coming unless we deal with whatever's going on that's causing that red light to come on in the first place. So indicator light means that, hey, we're on a path right now to bigger problems if we don't intervene soon. So universal, selective, and indicated. Again, we need strategies addressing all three of those populations. With indicated populations, it's things like an evidence-based curriculum delivered to people who've gotten a DUI. It's things like when a kid gets in trouble at school because of violating the alcohol drug policy at school, instead of just suspending that kid for 10 days, which is not a good prevention strategy. Nothing we want to do with a kid who's already engaging in antisocial behavior, like using as a teen, to give them 10 days off from school where they're unsupervised. It makes no sense. Instead, we direct that kid to, again, evidence-based intensive prevention education process. So we want to be able to have strategies that address all three of those. Clinicians. One of the areas where I think that treatment and prevention can work more effectively together is that when we've got an adult in a treatment environment receiving clinical services, are we directing that adult's family members to prevention services? Are we connecting with our prevention counterparts, either within our agency or in another provider agency, to ensure that the kids in that family or that other adults in that family are receiving solid prevention information and ideally prevention education, and also having some conversation about norms with even that family system. We don't do that. And we don't do it in a lot of healthcare. My father passed away of a heart attack 4 years ago. His fifth heart attack was the one that killed him. All the other times my dad had heart attacks, we would be at the hospital. Nobody at the hospital would sit us down and say, hey, looks like you might have some family history of heart disease. And we did, and we do. But no one ever sat down and said, this is what that means for you. Because we're a selective, my family is selective population for heart disease. We don't do it there. We don't do it, unfortunately, enough in our work around substance use either. And there are great opportunities to do that. So one area to kind of think about how do we collaborate to make that happen within our system. So a couple things on each of those three areas. With universal, the keys to universal, as I mentioned, evidence and research-based practice and strategies. And again, a lot of times that's going to be curriculum delivered within a particular environment. Focused approaches, so that we're not just doing this curriculum wherever folks will let us do it. We want to be culturally appropriate. We want to be making sure that we're determining what the education is that's most appropriate within that environment. How many of you are aware of the law that was passed a few years ago mandating school systems to do opioid education? Yeah. So every school district in Ohio is now required to do opioid education with students. This came out of the opioid epidemic. It was well-intentioned but faulty legislation. We don't have an opioid epidemic among middle school and high school kids. We have an alcohol and marijuana problem among middle school and high school kids, and if we more effectively dealt with the alcohol and marijuana problem among middle school and high school kids, we'd have fewer young adults with opioid use disorders. Because it's really hard to find someone, a young adult with an opioid use disorder who doesn't have a history of alcohol and marijuana use. But again, we kind of reacted to the opioid use disorder as a state and said, oh my gosh, we've got to help the kids, because we're always so focused on kids, that we immediately applied an adult problem, the strategy to address adult problem, to a youth population where we just didn't see the numbers. We just didn't see the numbers. So we need focused approaches. This doing universal strategies well provides a foundation for the selective and indicated strategies. With selective, as we mentioned, targeting the higher risk populations, again, folks in treatment recovery settings. Child welfare system is another one. Anybody here from child welfare? Yeah, a couple of you. Child welfare folks will tell you, I don't care what county I'm in Ohio, child welfare people will tell me 75 to 80% of the families they deal with, there is a substance use, at least one individual in that family with a substance use disorder. So again, we've got kids who are involved in the child welfare system, which means there's abuse or neglect. More often than not, there's substance use happening within that family environment. What kind of prevention strategies are we doing within child welfare with, again, the kids, and again, the other adults within that family system as well? Selective, again, one of the important things to recognize here is this is still prevention, not counseling. I've had clinicians say to me, well, we do family therapy. And so you're talking about family therapy here, right? No, we're not talking about family therapy. Family therapy is great, and it can be really, really important helping that family system. Family therapy does not show indication of having a prevention outcome. It can help family members deal with their feelings and their trauma and so on and so forth of living in that family system, but it's not a prevention strategy in terms of preventing use among those folks who are still cucumbers within that family system. Obviously, opportunities for collaboration, as we mentioned. We can also look at existing universal strategies and direct our selected populations to them. I worked with a coalition in Southwest Ohio a few years ago, and Mom and Dad were members of the coalition, very active in the coalition. Mom was in recovery. They had a 21-year-old son who had had various stints in treatment and jail because of opioids. And then they had a 15-year-old, and then they had another 15-year-old nephew that they were raising. And they were obviously very focused on trying to help their 21-year-old son get well and stay well, have sustained recovery and get the treatment he needed. And I sat down with them one day and let's talk about the two 15-year-olds in your house, because they're at higher risk. They're in a family system where there's a history of substance use disorders. They're obviously have some exposure to your older son, etc. And we got the two 15-year-olds to go to Ohio Teen Institute, which is a summer conference for prevention-focused conference for high school kids in Ohio. And so the two 15-year-olds went, and Mom went with them, because they have an adult track as well. So they spent 5 days at Tiffin University getting immersed in prevention strategies. And so as a selected population, Ohio TI is not it's a universal strategy. It's open to high school kids in Ohio. But we took two selected kids and put them into that universal strategy that's not open, not every high school student is taking advantage of. So be creative there in our thinking also. Indicated, when we again have those populations where we're already seeing the red flags. This is all about location, location, location. So it's about changing our policies in schools, in workplaces, court system, medical facilities, etc., to drive those folks who, again, are showing some red flags, use, inappropriate use, whether it's underage use or adult use that's resulted in some problems, but are assessed and are not needing treatment services, are not needing clinical services. Do we have a mechanism to get them into an intensive prevention strategy? Some kind of education program, typically, that's again evidence-based, that's going to hopefully stop things in their tracks. And then SBIRT. How many of you have heard of SBIRT or are familiar with SBIRT? SBIRT, for those who are familiar, stands for Screening, Brief Intervention, and Referral to Treat or Referral to Treatment. And it's typically been applied as a medical model in doctor's offices and other medical facilities, where there's a routine set of 4 or 5 questions that physician would ask me. It's been extrapolated to other environments outside of medical systems as well. We kind of a routine thing where I go see my doctor. Every time I see my doctor asks me 5 questions about my drinking, for example. Based on those questions, my doctor can do one of 2 things typically. One is refer me for a full-blown assessment. Basically say, hey Jim, based on this screening tool, this 5-question screening tool, we want to encourage you to get a full-blown assessment because you may have a substance use disorder. The other option is I'm not presenting as, there aren't that many red flags. It's not enough to, again, typically refer me for an assessment. But in the answers to my questions, I'm sharing that I'm drinking probably more than I maybe should. Then at that point, we're looking at a brief intervention. That brief intervention may happen within that environment. when the doctor says to me, hey Jim, I didn't know if you know this or not, but here's information about low-risk drinking guidelines. You're drinking above those. Not much above those, maybe. You're drinking above those. And what I would encourage you to do is follow these low-risk drinking guidelines, boom, 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 boom. Provide some information to me right there. Or refer me to, again, an established prevention education program available through one of the community providers. Here's my challenge with SBIRT right now. A lot of the times when I see active SBIRT programs happening in medical facilities and other environments, there's a lot of screening, which is great, and there's referral to treatment, but there's rarely brief interventions. And so if you're involved in an SBIRT or you're engaged in some kind of an SBIRT protocol somewhere, I would encourage you to drop back with that system and say, are we actually doing brief interventions? Are we providing opportunities for folks to get the prevention education they need because we're, again, seeing potentially drinking at a higher rate than they should, or again, medication use not being handled appropriately, et cetera. Not so much to the point where, again, the person needs treatment. They're still a cucumber, but again, indicated population. Any questions or other thoughts about those three categories? So I want to get to what people see sometimes, unfortunately, is one of the favorite parts of when I present, and that's talking about the things that don't work. What we would call ineffective prevention or not prevention. I'm leaning more and more to just calling this not prevention. These are things, unfortunately, that happen all the time in our communities, and they're a lot of times happening because of good intentions, but the research doesn't support them as being effective. One is information dissemination alone. We talked about earlier that I can inform people all day long, but that by itself is not going to typically prevent any type of behavioral health issue. Alternatives alone, as we mentioned as well earlier, we can provide all the kind of drug-free events we want to cucumbers, but those by themselves are not going to have a meaningful prevention outcome. One-shot presentations. And this happens sometimes in school environments and other systems where somebody comes in and does a 45 minutes and they walk out the door. And people go, okay, we did our thing. You know, we can check that box real quick. Again, probably not going to have any impact because, again, it's typically only going to be information dissemination in that environment. Signs and symptoms education. We don't prevent heart disease by telling people the signs of a heart attack. We can hopefully mitigate a heart attack experience by doing that, but we don't prevent heart disease by doing that. We don't prevent skin cancer by telling people what melanoma looks like on their skin, because once I see the melanoma on my skin, I have melanoma. It's not preventing it from happening in the first place. So when we look at signs and symptoms education, it can be really valuable education in some situations. It's not prevention. Recovery stories. Recovery stories, we're hearing some of them today. Recovery stories are really, really important and valid in certain circumstances. Things like today, obviously speaking with other people in recovery. They don't work on a prevention level. They don't work on a prevention level. And we see this, unfortunately. I just talked to a colleague last week who, one of the school districts she works with, had a recovery speaker come in and do an assembly with the students in that school district, and basically told their story. And it was emotional, and it was powerful, and all those things we would expect from a recovery story. We're not going to see prevention outcomes from that. We may see some kids cry. We may see some folks who just feel like they've been moved by the story. But we're going to talk about why those types of stories and strategies don't work, particularly with young people, in just a little bit. So recovery stories have their purpose. Again, it just has to be population specific about where they're presented. Relapse and overdose prevention. I have a friend who says we need to change the term here to relapse and overdose mitigation, because the fact we use the word prevention here implies that it's prevention as we understand prevention. When we're dealing with somebody who's relapsing or overdosing, we're almost exclusively, occasionally not so with overdose, but almost exclusively dealing with people who are already pickles. So those aren't prevention strategies. They're important strategies we need to have more Narcan available to folks. We need to be able to create stronger recovery supports within our communities, and that's happening in a lot of places. But that's not prevention. And then scare tactics. And scare tactics are the idea of let's scare somebody into engaging in the behavior that we want them to engage in. And again, those don't work. eye-grabbing, they're attention-getting, but they don't work. We're going to talk about why they don't work here as we go forward. I'll give you a few examples of things that are typically looked at as scare tactics. This was a campaign, some of you may remember this, so it did get a lot of play in Ohio, fortunately. Purdue Pharma, anybody know what Purdue Pharma makes? OxyContin. Yeah, so Purdue Pharma was already getting in trouble about OxyContin back in the late 90s. There were already some lawsuits against them because some people were experiencing problems with OxyContin in terms of, again, substance use disorders and overdose. And so Purdue Pharma created an education campaign called Painfully Obvious. And it was a curriculum delivered to elementary schools and other resources available to elementary, middle school, and high schools. And the idea was, this is painfully obvious. And you'll see here, this is just one of the posters. Picking your nose at lunch does not count as dessert. And spastic shaking caused by abusing prescription drugs is creepy. Basically, it's painfully obvious. And they put tons of money into this campaign, as you can imagine. They had the resources. And they wanted to distribute this throughout Ohio. They wanted to provide a whole big packet to every school district in Ohio. And the prevention community in Ohio fought this like cats and dogs. Because this is not an effective strategy. And again, we'll talk about why it's not effective here in a second. And we still see examples of things like this happening today as well. Sometimes this structurally organized, sometimes much more simple. Billboard that was up last fall, a year ago, in a community not all that far from here. Heroin is a trick, not a treat. Why do you think this wouldn't work as a prevention strategy? Who's the audience? Kids who are trick-or-treating. How many kids who are trick-or-treating are at risk of heroin use? No. Not one. It's a one-shot. It's a billboard. I drive by. It's not tied to any type of other strategy. It's targeting a population where this drug is not being used, and so it doesn't make a lot of sense. Not to mention, it has a counterintuitive effect of tying the term heroin to a popular holiday. So if I'm a kid who loves trick-or-treating, now you just subconsciously link heroin to my favorite holiday. So unintended consequences. Mock car crashes. Don't raise your hand, but think in your head, does your school district and the community where you live in still do mock car crashes? Where they put the big car that was damaged in a DUI crash, or they do the staging. This is obviously faked. The staging of the incident where they bring in EMTs and use community resources to basically show the perils of driving under the influence to kids. Some of them go as far as having funerals. I've seen schools have mock funerals as well. Why would this not work? Or why is this problematic? I'm 16. Tell me what I think when I'm watching this. I think I have the name. I'm 16, and a family member of mine was killed in a car crash 3 years ago. What does this do to me? Yeah, trauma. And so not only, again, is it not effective as a prevention strategy, it can be re-traumatizing for folks as well. So when we look at these types of scare tactics, why they don't work, typically 4 reasons. One is negative message resistance. This is true of all people. We all kind of have a not me attitude about things. It won't happen to me. That's just human nature. We tend to think we're more resilient. Teenagers in particular have a not me attitude, just because of brain development. Their prefrontal cortex isn't where it needs to be yet. And so they're thinking, of course, it's not me. So if I'm a recovery speaker and I'm coming in and speaking to a school district, and I talk about how I started with alcohol and then marijuana and then it was cocaine and then it was boom, 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 the kid in the bleachers is going, well, I just won't use cocaine. I'll stop with alcohol and weed. Because obviously things went wrong for him when he used cocaine. So it won't happen to me. And even if I did use cocaine, I mean, I wouldn't make the same mistakes that person did. Or my friends will watch out for me. Or, again, they're not me. And look, he's okay now, so it couldn't have been that bad. And so there's kind of this not me type attitude that particularly young people have. Young people also filter information differently than adults. And so when they hear information, they think about it differently than we do. They tend to focus on the interesting or cool parts of the story. I have a friend who grew up in Cincinnati, and she talked about, she had someone, a recovery speaker, come into her school district one time and did an assembly. And he told the story about one time when he was high, he broke into the Cincinnati Zoo and rode a camel, like in the middle of the night. And she's like, and that's all I can think about. The whole rest of the presentation was how freaking cool he rode a camel. And so she's like, I could tell you anything that happened after the camel, because I was just sort of like, he rode a camel in the middle of the night at the zoo. So again, they think differently than we do. Attraction to risky behaviors. If I am a, how many of you are parents? Keep your hand up if you have more than one kid. Keep your hand up if one of your kids, at least one of your kids, is the risk taker. It's the kid who wants to ride every roller coaster, wants to jump off the roof. Yeah. Risk-taking kids, scare tactics are bad for us, because risk-taking kids look at things like this and go, sounds kind of cool. You know? I'll take that risk because it's exciting to me on some level. And so, you know, watch me drive after I've been at that party and I've been drinking. I'll show you. You know, I can get home okay. I can even drive fast and get home okay because I'm a risk taker. And so, attraction to risky behaviors by high-risk populations. And again, there's a subset of particularly teenagers who are high-risk populations in terms of their engagement in risky behaviors. And then unintended messaging as well. We can send a message to folks sometimes with scare tactics that a problem is bigger than it is. So if I'm a high school student who goes through a presentation about the heroin problem and so on and so forth, and I'm getting all this information about why heroin's a bad thing, I may start thinking that most of my classmates are using heroin, which makes it seem more normative to me, or that heroin's a big problem within my population when it's not. And so we're shifting the perception of norms. We do this with adults as well. Have any of you ever been through the Hidden in Plain Sight program? Great program from an education standpoint. For those who haven't been familiar, it's basically a mock bedroom, teenager's mock bedroom, and you can, and it just looks like a normal kid's bedroom. It's kind of stuff in an auditorium or wherever the presentation's happening. And then the professionals, law enforcement or community agency folks, will kind of walk through parents and say, okay, this looks like a can of Coke. Look what happened. You can unscrew the bottom of it, and that's where you're going to find marijuana. And this looks like this, and basically sort of like if your kid's trying to hide substance use, there are ways they're hiding it in your bedroom and you're not seeing it. Hidden in Plain Sight is a great information dissemination tool from the standpoint of increasing awareness among parents. One of the unintended consequences that Hidden in Plain Sight can have is I'm a parent, and now I think that my kid's bedroom is a den of drugs, when my kid may not be using it at all, because most kids aren't using. We're currently, in the United States, 3 out of 5 kids by the time they finish high school have consumed alcohol. That means 2 out of 5 haven't. 2 out of 5 high school kids by the time they finish high school have not consumed alcohol at all. And if they haven't consumed alcohol, they almost assuredly haven't smoked weed, haven't used heroin, cocaine, et cetera, et cetera, et cetera. And so when we portray an image that, oh my gosh, you know, parents, here's what this bedroom, what could be happening here, we can increase parents' perception that the drug problem is bigger than it's ever been among teenagers. And it's actually not. We've got the lowest rate of alcohol consumption, lowest rate of smoking we've ever measured among teenagers, lowest rate of a lot of illicit drugs. Marijuana is an exception. We're not even at the highest rate of marijuana use that we've ever had among teens. And so unintended consequences, unintended messaging that sometimes makes it look like behavior is more normative than it is. So things like Hidden in Plain Sight are valuable, but they're best when we couple them with, and here's the stats, here's the information, and here's what you can do to keep your kid from ever having a bedroom like that. Here are the effective strategies that you as a parent can engage in to keep your kid a cucumber. If you find things in your kid's bedroom as a result of this presentation, here's where you go to get information and get your kid into a potentially indicated prevention strategy, or get them assessed to figure out if they need treatment services. So again, a good strategy coupled with other strategies that kind of provide a follow-up opportunity. Otherwise, again, that we can see in some unintended messaging of some of our scare tactics. So Daryl obviously talked a lot about the medical marijuana piece. I want to spend just a couple minutes here talking about what does this whole medical marijuana thing mean when it comes to prevention. Really, it's not, there are some customizable things we need to look at, but ideally we're still looking at our major strategies: environmental prevention and prevention education. From environmental strategies, Daryl talked about laws, communities passing ordinances prohibiting dispensaries from operating within their community or grow sites, for example. And that's an environmental strategy that's an appropriate thing to do. My town where I live, we're voting on election day for such an ordinance. We'll be voting on that. On a policy level with environmental strategies, as he talked about workplaces, schools, your agencies or systems that you work in, what do your policies say about folks using medical marijuana? If you're a clinician, has your treatment agency taken a position on one of your clients using marijuana, quote unquote, medically? So looking at policy in those areas. If you're an employer, again, if we're in an agency environment, we have an employer, what do our policies say about our employees and making sure that those policies are preventative in nature? Same thing with schools, etc. And then social norms and attitudes. We really, Daryl kind of referred to this, we've been behind the 8 ball on this. The social norms around marijuana use have changed drastically in the last couple decades. You ask teenagers today about marijuana use, and they see it as much less harmful than my generation did when we were teenagers. And that's not unintentional. The folks who've been advocating for marijuana legalization have done a pretty successful job in creating a message that marijuana is safe, that it's okay, that it's not harmful. So we need to start doing a better job of helping folks understand the harmful effects of marijuana, both on health and safety, as well as social norms about what's acceptable within a particular environment. One of the things you see up there, I've got quote-unquote medical marijuana. Part of it is helping folks understand that medical marijuana is not medicine as we understand medicine. It wasn't approved by the FDA. It's not gone through clinical trials as our medications do. And so I call it medical marijuana in quotations. That's different than legitimate medications going through the FDA process that have been evaluated, gone through that level of scientific scrutiny, and incorporated into approved medicines. This summer, the FDA approved Epidiolex, which is a medication that's using components of the marijuana plant in its composition. And it's an FDA-approved drug addressing 2 types of pretty severe seizures. And that's medicines, we understand medicine. It's going to be available in pharmacies, so on and so forth, prescribed by doctors, etc. Medical marijuana is different. It's, again, legislatively approved, which means it hasn't gone through the science. So looking at social norms and attitudes and figuring out what role we can play in shifting some of those so that even when this is a reality here in Ohio, that folks have a better understanding and can make appropriate decisions. Prevention education, that means that making sure that our prevention education in our schools or workplaces, etc., is again evidence-based and solid and addresses this. So if I am an employee in the workplace, am I getting education about what my policy says about me using marijuana, quote unquote, medically? Is that clear to me? Do I have that understanding? And then particularly looking at selected and indicated populations. The other piece that we look at here on what I call a small-scale environmental strategy is family systems. One of the things I've been saying to parents when I do parent programming is if you've got little kids in particular, but really all kids, but particularly little kids, one of the things that we need to raise our awareness about is, as Daryl said, there are going to be a lot of edible products. That's food. 5-year-olds don't care what's in a cookie. Okay? They eat cookies. And so where do my kids spend time? Whose houses will they be in? And is it possible they could get their hands on marijuana edibles within that home environment? Because they're 5 and they don't care about what, they're not asking questions about what's in the cookie. They just eat a cookie. And sometimes without an adult realizing they are. The other population that, for those of you who are animal lovers, is pets. We've seen in some of the other states an increased admission of emergency room admissions among little kids, 5 and under in particular, and pets because of ingestion of edibles, which tend to have, again, higher THC content. I always say if a kid doesn't care, a 5-year-old doesn't care what's in a cookie, the dog really doesn't care what's in a cookie. So something to be aware of there as well. And then for parents of kids as they get older, on an age-appropriate level, having those conversations about family expectations. Because for the first time in our lives here in Ohio, our kids are going to see marijuana stores. And seeing something that's publicly available and on some level has a public sanction can affect my perception, particularly as a young person, about whether or not that's risky or not. So if I'm seeing something, there's a reason we have more kids who use alcohol than cocaine. Because alcohol has been communicated to them as socially acceptable, at least as for part of our population. Cocaine has not. And so everything from an access and availability standpoint to, again, perception of risk can be affected by, do I see storefronts that are selling a particular product, even though I can't get into them. On the big picture level, how do we make sure all this happens in the way that it needs to happen? One is continuing to reinforce the importance of prevention credentialing. I'm an Ohio Certified Prevention Consultant, which doesn't mean a lot to most of you, but that means I'm certified in the state of Ohio and credentialed to do prevention. And I'm at there are 3 levels of prevention certification. I'm at the highest level of certification. That means I know things that not everybody knows when it comes to prevention. So working and encouraging prevention certification. The nice thing about prevention certification, because I mentioned there are 3 levels, OCPC, which is what I am, the OCPS, which is Ohio Certified Prevention Specialist, which is aimed at folks who are delivering prevention services, direct service providers typically. And then there's the Ohio Certified Prevention Specialist Assistant, which is aimed at coalition members and early career folks who have gotten enough education and training and experience, either on a volunteer or paid standpoint, to be able to say, I know some things, and can demonstrate that. And so encouraging folks at whatever level to seek that certification, because that increases the evidence base by which we do our work and ensures that folks are legitimate in their knowledge base. Utilizing movement that utilizes science. So we've got a lot of energy around prevention right now. The opioid epidemic has drawn a lot of people into wanting to prevent substance use problems in our communities. Let's harness that movement and couple it with the science so that we're doing effective strategies. And some of the what we call family engagement groups, the organizations that have come together, typically driven by parents or other loved ones, people who either have died of overdoses or have been engaged in treatment. Let's harness that energy and couple that with the science of prevention professionals to do strong prevention strategies within our communities. That also means, of course, linking with our key stakeholders within the communities as well. And, of course, purposeful use of resources. We spent 20 years, more than 20 years in the United States, spending money on curricula that didn't work, that we had the research that showed that didn't work, prevention curricula in schools. And we're getting better about saying if a curriculum is going to be delivered in a school district, then it needs to be evidence-based, that the research supports it being effective. We need to be better about how we use our resources because we know our resources are limited. Other key issues, if you're not a prevention person, you still play a role in prevention. Sometimes you can be the advocate championing prevention within your system, within your community, etc. And you can open doors for that prevention professional who probably isn't in a position of authority. We have 50 county boards in Ohio, county mental health and recovery services boards in Ohio. One of them has an executive director who's certified in prevention. Many of them have staff who are certified in prevention, but they're at a lower level on the totem pole. We need more prevention people in those leadership positions. We also need the people in leadership positions who aren't certified to open doors for the folks who are prevention certified, for the professionals who are doing the work. We need to infiltrate, we need prevention in infiltrating child welfare, the court system, all the other systems that we're part of, and it becomes an embedded part of our protocols there and our processes, and is on the front burner of the decision makers' minds when we're looking at how we address issues. And we need to evaluate. We need to evaluate strategies and continue to figure out what works and what doesn't when it comes to prevention. We've got a lot on some existing strategies. Folks are coming up with new strategies all the time. We need to make sure we're putting money towards evaluating new efforts also. Some resources I want to let you know about. Prevention Action Alliance is a statewide organization that does a lot of really, really good work They were referenced on the one slide where I talked about scare tactics. This document is well worth, I think, the $5 it costs. It is a document that talks about scare tactics. It cites all the science. It's really, really good. You can buy them in bulk. I would encourage you to go there and do that. Prevention Action Alliance has a lot of other programs as well. They work with family engagement groups that are trying to address the opioid epidemic and other things. They have a program called the No Campaign, KNOW, which is a campaign where if I'm a parent, I sign up for it, and twice a month I get an email that provides me with the language on how to talk to my middle school age kid about a particular topic related to substance use or other behavioral health disorders. That language is based in science and research. So some really good, effective strategies they have, and their job is to provide those resources throughout the state. ADAPO, the organization I serve as the executive director of, is again a professional organization for prevention professionals in Ohio. Another resource, particularly for those of you who are either already in the prevention field or looking to become more engaged in that. The credentialing board for folks who are wanting to seek certification as prevention professionals, and Ohio Moss, the State Department that funds many of us in this room to do our work. The prevention tab there, lots of really good resources there as well for folks who are looking for more information. And you can always email me as well if you have further questions after today. I'm really happy to. Questions?
You talked a lot about what doesn't work, but you didn't talk much about what does.
Go back to the... So I didn't call out particular programs, but it really comes down to the so prevention education, it's things like programs like the Alcohol Literacy Challenge in schools. It is Too Good for Drugs, another school-based prevention program. So there are particular curricula. If you want names of those curricula, email me. I can send those to you. On the environmental standpoint, same thing. We know that there are some laws that work. We talk about the opioid, the restricting prescribing or changing the prescribing guidelines. We know that things like raising taxes on alcohol products is another good, effective legal strategy because it makes it less likely kids are going to buy it because alcohol gets more expensive. The increase in the minimum drinking age was a very successful strategy, most effective strategy we've ever had in the United States. So you're right, I didn't call out specific programs in those areas, but if folks want specific programs aimed at particular sectors, please email me and I can send those to you. The key with the education is evidence-based, that it's approved by an independent entity that has done the evaluation. We used to have NREP, some of you are familiar with NREP, National Registry. That got the list earlier this year, so we don't have that laundry list. But there's another one called Blueprints for Healthy Youth. So if you're looking at youth-based prevention programs, Blueprints for Healthy Youth is a website, you can just Google it, that will basically show you the different school-based curricula and other school-based strategies and provides an evaluation of those. And so Blueprints will be where you want to look if you're looking at youth-focused prevention strategies. On the environmental standpoint, again, it's looking at what are the laws and policies and such that are effective. I can help with that. Prevention Action Alliance is another entity that can help with that as well. Good question. Other questions? Yes?
Well, you talk about cigarettes now. A lot of these young kids nowadays, when they start getting cigarettes.
Yes.
Now, they like Juul, and all that stuff. I think that's going to be the next goal.
It is, yeah. Yeah, the tobacco industry is pretty savvy.
Oil for
Mm-hmm.
marijuana, they put it.
Absolutely.
And you give kids cigarettes, they're out at the state, they're all like fun stuff.
Yeah.
And, weed and all that stuff. And I think that's going to be the big.
Yeah. Yeah, we did a great job of changing the social norm around tobacco, as we talked about smoking in particular. And obviously, in Ohio, that led to the state law change. I always say, most of us in this room, if I asked you where you saw people smoking when you were a kid, you'd name places like restaurants, everywhere. 30 years ago, there'd probably be ashtrays on these tables. Airplanes. Ask a kid today where they see people smoking cigarettes, and they'll be like, so-and-so's house. People outside in the winter, outside, they don't look very happy. We in some ways stigmatized smoking. But the tobacco industry got smart, and they said, we're going to go a different route. And there's a perception of harm. Kids see smoking as harmful. They don't see vaping as harmful because it's not smoke. And you're right, there's a crossover between tobacco, marijuana, and some other products as well. So you're right, that's a new horizon area that there are a lot of communities who are doing a lot of prevention work around those areas. But part of it is that first step of raising awareness, because you just mentioned jewels. Most people have no idea what you mean when you say jewel. They think you're thinking about sapphires and diamonds. So part of it is we've got to raise the awareness and then start implementing the strategies. I think we're about done, yeah, because we break. Folks, thank you. I'll stay around for a few minutes to break. Folks have individual questions. Appreciate your time.